Great. Thank you. Good morning, everyone, and welcome to our quarterly meeting of the Essential Workforce Advisory Council. Essential Support Workforce Advisory Council. I missed a word. And I'm Jess Bauer. I am the current chair, and I think we will start briefly with introductions, if that will work for you all. We'll start with members, and Catherine, do you want to go?
Hi, I'm Catherine Thibodeau. I'm the Executive Director of Independence Advocates of Maine. I'm the Vice Chair on this committee, and I represent MAXB, an association that supports supports providers of individuals with intellectual and developmental disabilities, autism, and brain injury. Thank you.
Thank you. Betsy?
Good morning. I'm Betsy Sawyer-Manter. I'm the CEO at Seniors Plus, and I'm here representing the care coordination function in the long-term services and support system.
Great. Representative Craven.
Yes, good morning. I'm Margaret Craven, and I serve on the Health and Human Services Committee and have been absent a lot, but I'm delighted to be able to attend this morning. Thank you.
Thank you. Kim.
Good morning. I'm Kim Moore. I'm the Director for the Bureau of Employment Services here at the Maine Department of Labor.
Thank you. Stephanie.
Good morning. I'm Stephanie Hatcher, Director of Training and Onboarding for Northeast Residential Services. I sit on the committee as a representative for the direct service workers.
Thank you. Michael.
Morning, Michael Smith with Catholic Charities Maine as our Chief Program Officer, and for this group serving for the Independent Support Services or the Homemaker Program.
Thank you. Mary Jane.
Good morning. I'm Mary Jane Richards. I'm the CEO for North Country Associates. We own and manage long-term care and assisted living facilities throughout Maine.
Great. And with us today, we have a guest. Malory, you want to introduce yourself?
Sure. Hi, I'm Malory Shaughnessy. I'm the Executive Director at the Alliance for Addiction and Mental Health Services of Maine, which is an association of providers of those services for Maine care and uninsured.
Thank you. We've got two wonderful staff folks with us today. Angelina, do you want to introduce yourself?
Hey everyone, I'm Angelina Cluthis-Jean. I serve as the Director of Strategy and Innovation for the Bureau of Employment Services, but today I am your Zoom host. So if anything goes wrong or you need some tech support, please don't hesitate to reach out to me.
Fantastic. And Dylan.
Good morning, folks. I hope you can hear me. I was having some audio issues earlier. Oh, wonderful. Dylan Murray, I'm the Legislative Liaison with the Maine Department of Labor. It's great to be here.
Excellent. And I don't think I said exactly who I am. So I'm the Executive Director, Jess Bauer again, Executive Director of the Maine Council on Aging. So I think our first order of business today is that we are required to annually elect a chair and co-chair or vice chair, actually, to chair the committee for the next year. And so we thought we would start with that and open it up for folks to say that they are interested in chairing or vice chairing the committee.
I would move that we retain the current slate of officers.
Second.
All right. Is there any other nominations or motions? All right. Well, then let's take a vote. Is there all in favor?
Aye.
And any opposed? Any abstaining? Great. Thank you. And I see that Ben has joined us. Hi, Ben.
Hi, good morning.
Would you mind introducing yourself as a guest?
Yeah, certainly. I'm Ben Hawkins from the Maine Healthcare Association, and I serve as their Director of Public Affairs.
Terrific. All right. So we have sort of a just a piece of order, which is addressing our schedule. We are scheduled for August 12th, November 11th, and February 10th of 2025. It says 2024. And Angelina has noted that November 11th is Veterans Day, which means that that needs to be adjusted. And so I'm gonna propose that we just jump a week if that works for folks, but that moves us, so that would be November 18th.
And just, this is 2024, right? We're talking about not
2024. Yep, 2024. So would folks be okay with shifting to November 18th? All right. Any opposition? Great. And we'll move ahead with that. And Angelina, did you have something else on the schedule? Perfect.
I will go ahead and send out a calendar invite after this meeting so that folks can have that updated version.
Thank you so much.
I think we were also gonna check in on I think we had talked about checking in on that August date and just seeing who would be available then, since August is often a skeleton month. I don't know if we want to do that, or are we good with just keeping that August 12th date?
Are folks able to generally attend that meeting?
I can do that date.
It still works for me as well. So I think we'll keep that date then. I think the next order of business is a discussion, and I will just sort of say I've been looking at the recommendations from the report from the Commission to Study Long-Term Care Workforce Issues, really trying to identify other pieces of work that are left to be done, and noted that one of the recommendations in that report was to address issues related to apprenticeships, and thinking about how we can potentially move the needle on sort of an earn while you learn or apprenticeship specifically for the lower rung workers, the entry level workers, sorry, who are potentially interested in things like becoming a PSS or a DSP, a BHP, no, behavioral health. What is it, Mallory? Sorry.
BHP.
BHP, I got it
Behavioral-
right. I
behavioral
thought
health
I
professional.
thought the P might be wrong, sorry. So really wanting to think about how can we give people the opportunity to test it out, and to see what's possible, and how they might want to work, how challenging it might be to be a PSS, but might be perfectly great being a DSP and in a residential facility. So anyway, what are the opportunities that there are? And so we asked Kim if she might share some ideas and information about apprenticeship programs, and then we can maybe have a conversation about what we might want to recommend in relation to this. So I'm going to turn things over to you, Kim.
Sure. And Catherine, I may have gotten a slightly mixed up memo, but we're gonna get through this. So I think that what I kind of built a presentation around, I'm happy to share my screen in a second, was kind of, again, how can employers create those opportunities for both no and low cost exploration of direct care careers? And then we can talk a little bit more about some of the cost, and just I'll hit on all of those. And I might need to promise that I can dig a little bit deeper into the specific ones, unless I can ask Angie to put her other hat on and help me out there. But let me get started here. Slideshow from the beginning. And I'm going to share my screen. Bear with me. Screen 2 looks like it. All right. Can folks see my slides?
We can.
Perfect. Thank you. All right. I figured, again, I would start out a little bit with some of those no cost opportunities. And again, I wanted to kind of start with really, what does trying it mean to you as an organization? So what is the thing? What could a job seeker do or see, experience on your work site to determine if they're right for the job and if that job is right for you? And then how long would it really take? Is it, I could do a quick job shadow with someone and, oh, yep, I got it. Yep, I know right off the bat, this is something that's good for me, or I'm not a great fit, but maybe there's another better fit. Or is it something that I experience it over a week, a month, a year, and then I learned that maybe it's not exactly right for me. So So again, I would encourage everyone to kind of think about, you know, what is the thing that's going to make that kind of change. And then I try to toss out some, again, no or low cost exploration opportunities. Some employers have had a lot of success organizing open houses, structured tours, that kind of stuff that really expose job seekers to the work and to the environment, the sights, the smells, the people, the training, the everything. I see Michael nodding. Thank you. Or he's nodding at something else.
No, I'm
The
nodding
other
because
one-
this is right up my alley. I can't tell you how many staff we turn over within the first day.
Yeah, absolutely.
First time they walk in that door, as much as we prep them, we talk about it. But like you said, they see, they smell, they interact, and they said, this is, even though you paint the picture, this is totally different. I mean, it's got to be around 30 some odd %. I mean, the first
just
day.
walk out first day.
Yeah, can't handle this, right? And we try to match them up with the right consumer as to this is, you know, male or female, smoking or not smoking, trying to reduce as many barriers as possible. But it's amazing how that, so how to simulate, emulate that. I would love to hear what you have to say. So sorry to interrupt, but yes, it definitely resonates on my end.
I want this to be a discussion because, perfectly honest, I don't have the perfect answer, and I don't know, maybe somebody in this room does, and let's make sure that they share it. But again, Michael, you're kind of going down the road of maybe it's a job shadow. Maybe it's that I'm able to, and again, being very careful in a healthcare environment. I know there's lots of rules and regulations and stipulations, and what could it look like to be able to create somewhat of a job shadowing experience? So again, you can kind of experience that day one before we've signed the employment paperwork. Another way that individuals can
Did Kim freeze for you guys?
She did.
Oh,
Hopefully she comes back. Oh,
She's calling in from the office where one would think the internet could be at its best as well.
the talk.
Oh.
Am I on?
Kim, your noise is back, your video's off.
Yes, I've turned my video off just in case, because yes, I am in the office, which you would think would have a nice secure line. Everybody hear me?
We can.
Perfect. All right, I'll keep my video off just for now. All right, please let me know if you can't hear me again. Thank you for Augusta office. So I was just pointing out that this third bullet here is one that really kind of encapsulates a lot of different things and kind of all chunked under what we call traditionally as a work experience. Generally, that means that the individual is getting paid for some level of hours, days, weeks, and generally the employer is not having to contribute to that one. So that could be through some of our partners, like our Workforce Innovation and Opportunity Act. We fondly call it WIOA. They regularly work with individuals who say, you know what, I really think healthcare is for me, but I don't have a lot of the experience or training, or I have the experience or training, but I'm feeling a little shaky. Maybe I'm not being really successful in my interviews, and maybe a work experience is something that will really help me to build my confidence, my resume, my everything. So again, that's something that is the full burden of funding that individual, and their employment costs are on the provider. So it could be vocational rehabilitation, could be that WIOA partner, could be the Senior Community Service Employment Program, fondly known as CSEP. So again, we're trying to make sure that that individual is getting the skills. There's not a commitment to hire at the end of that one for the employer. So of course, they are always welcome to hire. The other one that I know that Jess, I'm almost positive you wanted me to focus on was the CTEs, and especially I'm going to point out the extended learning opportunities. CTEs, of course, have some of them have a smattering of programming related to healthcare across the state. The other really cool opportunity that sometimes is embedded in a CTE and often is just embedded in that high school is an ELO, or an extended learning opportunity. So that's going to be a hands-on credit-bearing experience that's outside of the traditional classroom, and it emphasizes community-based career exploration. Again, and it's usually paid by the school. Again, they're hosting all of the workers' comp, taxes, everything like that. They're issuing usually a 1099 to the individual who's participating. So again, that's a nice opportunity to connect with potential workers. Another one that has just started developing over the last couple of years, and we have some really interesting projects in healthcare in particular, is around pre-apprenticeship. And pre-apprenticeship is that on-ramp to apprenticeship. So it's usually going to be, there's probably hands-on experiences. There could be industry recognized credentials, but it's not going to usually be your full-fledged training. Usually that's going to be embedded into your registered apprenticeship. So it's a little bit more about career exploration. It's about developing the core skills that you might need in order to be a good employee and to, again, really understand what aspects of the career you might be interested in. What else? Career exploration. This is another example, particularly in Portland and in Lewiston, where some other core skills have been built in. So Portland Adult Education, Lewiston Adult Education have also embedded English language learning skills. So really contextualized learning to be able to walk onto the job and understand the words that are used in healthcare. And of course, you guys know that often individuals that we're working with who we consider recent arrivals do have that background in particularly healthcare, which is awesome. What's challenging, though, is that they know all the words to use in their language, and they don't know the words yet in English. So this is a really great opportunity to not only allow them to explore the opportunities that are here in the United States, but to build their US or their English language that's really contextualized to the field. Let's skip the next one. All right, now we're going into paid. So this is a little bit of the earn while you learn opportunity. So I am going to go ahead and click on this because one of the places that we're going to look for, or that job seekers are going to look, is our healthcare training for me site. We have a earn while you learn. Let's see if this actually works. Hold please. I'll scoot it over here. Never mind how many tabs I have open. It's actually not too bad. All right. So really great. You can take a look at some of your colleagues who have developed some Earn While You Learn opportunities across the state of Maine. Earn While You Learn is usually just that. Usually individuals are started in an occupation that don't require the specific credential in order to do the work. So maybe they're not quite a trained DSP yet, or they're not quite PSS or CRMA, but maybe they're getting used to the environment and getting paid while they're in training in dietary, in laundry, in companion, something else that doesn't necessarily take the certification or the time that's going to be needed to be invested in some of these other occupations. If you have any questions as I keep going, my face is open to to questions. You can't see it, but it is. I'm going to scoot back to my presentation, which is here, I believe. Yep. Next one is registered apprenticeship, and we talked a little bit about this before. This is a job, but again, it's an individual who is kind of on that career path to get the skills and abilities that they need in order to get that great job. Things that we know about registered apprenticeship is that that's a great opportunity for folks to onboard, so have people enter into their workforce, and to help people move up along the career pathway. So the next step, whatever it might be. They get paid while they're on the job, while they go to classes, and they're going to earn a nationally recognized certificate. Registered apprenticeship does have to take at least 2,000 hours of on-the-job training. They get 180 hours of classroom training, and that can vary. Individuals can also kind of not opt out because they don't get that choice, but they could essentially test out. So if they come to you with pre-existing credentials or training, then they can quote unquote test out those things. The thing that we know about.
Kim, this is Betsy. I have a question and a comment, I think. To me, this is very similar to internships. And a lot of the like schools of social work, for example, require internships. And one of the career sort of obstacles that we've come into is if we take a student as an intern, they may have the great background. They may have the skills to do right out of the gate, do really good, high level work. But we're not allowed by the department to let them bill for the work that they're doing. So they can't work for us. So I found that to be very frustrating, and I don't know what to do with it. I'm just putting it out there as an obstacle that if there was a way around it, I think we could get, particularly the higher level jobs like care coordinators, that kind of thing. I think that could be a really good pathway.
Sure. That's a great question and a great distinction. So, internship meant to be temporary, right? It's they're getting it for credit. They might do it for a semester, maybe longer, maybe less. Registered apprenticeship is a job. This is, you have hired this individual, you intend to keep them on, and they're, before they get to what we, it's, apprenticeship may or may not have started in the trades, so we call it journeyman status. So the individual who really has gotten the credentials that they need to do the job. So Betsy, that's a really, really great point. And I'm not going to pretend that I know much at all about what it takes to be able to bill for services. But this individual, again, is a full-time, well, I shouldn't say full-time, they are a hire, they are an employee, and at whatever stage a normal, regular employee could be able to charge for those, they will be able to charge for those. They are your employee. And they, again, my next point, 90% retention rate nationally for registered apprentices, and that's across all industries. And we do have not a huge, a solid number of opportunities for registered apprenticeship, I mean, all the way up to psychiatric nurse in healthcare.
Is Kim, it's Catherine, is there, so it sounds like there are specific positions that apprenticeship can apply to. Is that,
yes,
am I hearing you right?
So yeah, so let me dive a little bit. Yeah, let me dive a little bit deeper into that. Hang on, okay. I'm going to try to.
Okay.
All right. Now you guys can realize that I can't type. Maine apprenticeship. I can type better than that. All right, Maine apprenticeship program. I don't know if you have been to the Maine apprenticeship programs website lately, but it's pretty darn good. We were able to invest a little bit of funding into the site. So Catherine, when you say yeah, it has to be a certain career, absolutely. And the reason that there's a specific career attached to, let's just do this. Well, I could do both. Occupation. I could, there used to be, hang on, let's go to the searchable table. And let's go to healthcare support, might as well. There we go. So this is just a different way to look. So you can see that there are apprenticeships as healthcare support, CNA. Oh, Educate Maine is what we call an intermediary, which is a great way if apprenticeship feels like it's a little overwhelming for your organization or your company. There are some awesome intermediaries out there like Educate Maine who kind of serve as that paperwork kind of person. So you are still registered as a sponsor. Your company is registered as a sponsor, but they're kind of that umbrella organization. I'll keep scooting down. We got Psych Tech. Wow. Maine General has a ton. Medical assistant, med tech, medical assistant, and there's a DSP. Housekeeper, medical assistant. So we like to say every occupation is apprenticeable. Ish. It does, of course, have to meet that requirement. But we have an amazing team and a bigger team than we've ever had before on the Maine apprenticeship program that can help you figure out what it might take to make an occupation apprenticeable. Each one of the occupations that you see on here does have to have a schedule of work. So we have to work with you, and we do a really nice job of making it easy for you. We have to work with you to make sure that we've identified what does it take? What are the things, what are the steps, what are the credentials that it take in order for an individual to be competent or that journeyman at a career. Any questions?
Kim?
Yeah, go ahead.
I'm sorry, this is Stephanie Hatcher. I just wanted to, because our agency is up on the list,
Yay.
Northeast Residential Services, we have gone through the process. We do have an apprenticeship program for a direct support professional.
Yep.
We haven't had the opportunity yet to have anybody go through the program, because we've found that having applied and gone through it, the program goes towards people who want to advance within the field, and where most of our direct support professionals don't want to advance up into management. They want to stay at the direct support professional position. The biggest challenge being is in the management realm, the hours don't really allow for second or third jobs, which most, probably 95% of our employees have 2 or 3 other jobs. So we've gone through the apprenticeship, we've been approved, but we haven't had anybody that has wanted to go through the program yet.
Gotcha.
We're still searching, and it is something that we offer to many of our newly hired employees.
Yep, great. Thank you, Stephanie. So that might point me in the next bullet, the direction of the next bullet. So on the job training is another thing, Stephanie, that might be interesting, particularly in your case. So it's that onboarding. It doesn't come with has to have 2,000 hours, 2,000. None of that. Has to be at least a year of training. On the job training is usually a 50-50 arrangement between the employer and a provider. Again, usually this is through the Workforce Innovation Opportunity Act. I believe FedCap has this as well for their Aspire folks who have work experience. Paul, correct me if I'm wrong, or if you don't know, it's okay. Vocational rehab also has OJT, but it's what you need in order to get an employee up and running on the job. And this is in recognition that it takes time and that takes supervision, and that all comes with a cost. So you work with the provider to create a contract, a training schedule. Stephanie, probably not too dissimilar from apprenticeship, but a little less intense. And you talk about what is it that they're going to be doing for the first 2, 3, 4, 6, 8, 12 weeks on the job. And then contract is signed. And then again, that reimbursement's usually at a 50-50. So you're going to get 50% of the employee's wages back in return. I am going to scoot one more down. Catherine, I remembered I had this when we were talking. So Catherine said, hey, you know what? I'm going to ask if there could be a 1-pager on this. And I said, oh, goodness, we could very easily put that together. Except I think we have something that we can at least work from, if not share. So this is a handout that we shared, or that we developed with Department for Economic and Community Development for when they're talking with businesses. So you'll see the range goes from raising those career aspirations, so working with high school students, developing those skills, connecting folks to jobs and wraparound supports that they need to get to work and stay in work, upskilling and retention, and then creating those sustainable job opportunities. I am happy to share this handout with everyone, and it does, I think it has just about everyone that I would have told you to go to. So if you look at supportive services for workers, you've got the links for our providers there, EMDC, Workforce Solutions, and ACAP. I could wiggle my mouse since you can't see me. So that's right around here. Again, this is the OJT, and again, who provides those. So again, it's not extensive, or it's not as expanded as my presentation was, but I can add those as well. It's a lot of information. There's a lot of stuff. And the one thing that I want to always bring folks back to is that we at the Career Centers are here to help. So if you have a question, if you need a brain partner, you need a strategist, please feel free to reach out to your local Career Center. We're on live chat, where you can, of course, come visit or call one of our local centers. or you can shoot us an email and we'll send you back our best recommendations. But our job is to really make sure that we're making the connections that you need to get the workers that you're looking for.
Can I ask you a question? This is Mary Jane from
Yeah.
North Country. We have one of our facilities is St. Joe's. It's in Portland, Maine,
Yep.
and they focus a lot on new Mainers,
Yep.
and they support them with training even in English as a second language. It's a huge investment by the facility. It takes quite a bit of staff to support that program, but it has been very successful. So is there help with that from the Department of Labor, like support that we could get from the department to help augment that support we have to provide them?
So are you talking about as you're on the job supporting them with English, or
Yes.
during
Yep.
the training, or both?
Yeah, so in long-term care, CNAs, direct care staff, they can work for up to 4 months while they're on the job training as a CNA. But before they even can do that, they have to learn English typically. And so I'm just wondering if there's any support from the department to assist with that, because it takes quite a bit of manpower to support that program.
Yeah, and so I came here from Portland and I helped to develop the Bridge to CNA program, which is
Nice.
exactly focused on training individuals who might be speakers of other languages, specifically in the healthcare field. So one of the pre-apprenticeship programs that Portland Adult Ed, for example, is working on, or is actively working on, is exactly what you're talking about, is helping individuals with those base English level skills in
Okay.
order to go into the job. So
Okay, good.
St. Joe's, I'm almost positive, is already sourcing from there, but may not be. If you're not yet, that's a fantastic place to get connected to, because they're working with these students constantly.
Okay.
And they've expanded it. It used to be just to CNA, and now they've expanded it to healthcare careers. So they're doing a lot more exploration around what different types of careers are there.
Okay.
So that's a great opportunity to make sure that if they're doing company tours, if they have people
Right.
come in from HR to do interview skills, that you're getting some of the top candidates coming out of there.
Okay, great. Thank you.
No problem.
Catherine?
So I have a couple questions. One is just sort of a general question. The Healthcare for Me program, is that time limited tied to the ARPA funds, or is that going to be a program that's extended beyond that?
So healthcare training for me, the website lives on forever.
Okay.
The funding, for example, tuition remission funding, that will
Yep.
help individuals
Right.
already employed upskill, or new hires get connected, that is time sensitive. So that one's going to time out by December of 2024.
Okay.
Of course, there's also Alphon funding and other things.
Yeah, when I saw that website, I was really about the website.
That we are committed to, and
Yeah.
it's not bad now, but there's a project that will make it even better and more streamlined in the future, which we're really looking forward to. And healthcare is the first sector that we've tried this on.
My other question is probably more broad. Well, it definitely is more broad. So one of the things that I'm curious about, if there's a way to think about it or a way to talk about all of these opportunities, is there's opportunities that are like, who, for lack of a better word, who drives the bus in them? Like, is it something that the employer can tap into and set up and create and get funding for, or is it another entity that they need to partner with, or is it another entity that they need to source employees from? Just sort of trying to think about that, because it's complete alphabet soup to me, all of those things, right? But finding a way to sort of, as employers that are trying to connect with workers, sort of what are the pathways that can happen? So that might, if there's some other kind of infographic that we could have towards that, or I'm just curious also about how others are feeling, but I feel like in our industry, there's really a gap of knowledge of opportunity. But I think there needs to be more than just I'll just speak for myself. I think for our agency, we need more than this is an opportunity out there. We need sort of like, this is how you access it. And this is how you would, you know, like really, really explain it in a way in depth would be helpful. But you know, and Michael seemed interested. I'm just where we could go from here to bring this sort of more to the attention, or maybe that is just an isolated thing in my world and other people know about, you know, I'm not
No
going to
way.
assume that where other people are at, but for me, I'm like, oh my God, there's so much opportunity here, both from a provider association level, from a collective healthcare workforce level, from an employer level, you know, so.
Yeah, I mean, never going to be perfect. And what we like to say about our system, and I like to believe it's true, they'll let me know if it's not, is that there should be no wrong door. So if you say, you know what, that OJT thing sounds really interesting. Oh, Workforce Solutions is the place in my area. You talk with Workforce Solutions, and what you're talking about is not actually up their alley. It's more, I don't know, you want to do some career shadowing, whatever. I can't say job shadowing. Or a company tour or something else, or you really need help with training, they should be the one helping to give you that warm handoff to the right partner. The place that you can always go, and please let me know if it fails because we'll fix it. But the place you can always go is the Career Center. We're the ones who are supposed to have the finger on the pulse of all the stuff that's going on. And we do have, well, did have two, one moved on, and we'll have two, but we also have healthcare navigators. They're also dedicated, and it's Angie's team, they're dedicated to working with employers and helping them to connect with the resources they need. And they're the phone call you can always make.
Quick question on that, Kim. Are those temporary jobs also funded through ARPA or?
So currently they are funded through ARPA. We are excited that we're able to, in most cases, continue those positions for 1-2 years. And the other good news is this is not going away. Our sector specialists, first of all, we hate losing people from the Department of Labor. So we usually fold them into our staff. And in sector focus is the wave of the future. So we want our Career Center consultants to have that sector specialty. So are we going to abandon it? No, we're probably going to expand it a little bit more. See where we can give other ones of our Career Center consultants kind of those specialized skills, superpowers, as we like to call them, so that they're making sure that we're really focused in and hitting the needs of our priority sectors in Maine.
Great. Michael, I don't want to put you on the spot, but did you hear anything there that would apply to the workers in your workforce?
Not right off the cuff, and it's partly because I would say we're a little bit of a unicorn, right? Like it doesn't take any educational lift, right, or skill sets to move into. And similar to, I forget who spoke earlier, it's typically we've found that our workforce doesn't want to move on. Now we're trying to tap into a different workforce in terms of attracting to them to see that this is a place that can be full-time and can have some progression, but that the workforce that has come to us has been very much, you know, they want to work in their own schedule. They want to have that flexibility and do limited amounts. And it comes in with ready-made, right? I can clean, I can grocery shop, I can, you know, it's not any additional levels of skill sets required for that. So, but again, we do a little bit, can we do a little bit of sort of mentoring, like you said, it sets up any new employee up for success. We try to have them go out with someone else for 2-3 times to learn best practices and understand, kind of ease that into it versus great, welcome, you know, good luck, go to the first home, you know, kind of thing. Well, so that certainly is a helpful practice in terms of sort of skilling, but also just retaining employees for sure. Absolutely.
Yeah, for sure. That is one of, it's proven, I believe, one of the reasons that registered apprenticeship is so successful is because of that mentor kind of relationship. You've got a person, you've got a guide, you don't feel like you're out there alone. And it's pretty structured. They're there for you. So I think that's a really great approach, Michael.
We almost thought about like trying to do a video or something. Again, we talk about it, but almost, you know, not trying to show any client specific information, but just generally speaking, this is what a home might look like. Yeah. Here's some scenarios you might walk into as a way to help emulate that a little bit, even at an interview time frame, right? As a way to and help embody it. So
it was the Maine Healthcare Association, I believe, that had done some really, really neat videos back when I was in the field. And we would always use it as part of our training curriculum because they were real. They were, here is a day in the life of an individual who's in a long-term care facility, or it was really kind of neat.
yeah, absolutely.
So I heard I heard a question, although Stephanie didn't ask one, and Michael too, but I think WIOA and some of these other pieces, you know, in terms of job quality and also advancement, are some barriers, right, for employers who are actively seeking and wanting to employ people or are employing people who just love their job, who are good at caring and who aren't interested in advancing and who do, as Michael say, want to work in a flexible environment. And yet we have, I mean, I remember 2015, I think we were down in Portland. We had first hosted the first conversation about this, and with a bunch of really smart people in the room. Kim, I think you were there.
I think I was.
You were there in a very different position than you're in currently. It was the first time we ever met, actually. Almost a decade. But I remember, you know, sort of the story after story of people not, you know, sort of not being ready, this readiness problem coming into these jobs. And when I hear Michael say somewhere along the lines of 30% of the people they hire are leaving after they walk in the door, that's, I mean, to me, and I know the same as we don't have a PSS representative right now, but I know that's the same situation here for PSSs. So we have barriers. And then I think about, right, this is the point of this group. What are some things that we might think about doing, right, to create that opportunity for people to get real hands-on in the door opportunity before they sign on the dotted line, before employers spend significant amounts of time? How can we think about care in and of itself being an important thing that this state wants to make sure we have an adequate care workforce? And some of those people will advance, but a lot of them won't. What do you have any thoughts? Have you seen anything in other states that could move us in the right direction for supporting those sorts of workers?
My finger's not necessarily on that pulse, but I've got a National Association for Workforce Development Association, I think is what it is. I've got a meeting in Burlington here in the next month, so I can make sure that I ask about some innovative strategies. It usually has every state there, and it's folks like me or folks who know people like me. They're usually higher than me. So what was the other piece I wanted to say? Oh, while, of course, in Department of Labor, U.S. Department of Labor, good jobs is, of course, the emphasis. And I would argue that what a good job is can vary from person to person. So Jess, again, Mike, you were talking about it as well. An individual who needs that flexibility to care for children, to care for parents, to care for themselves, to care for whatever, that makes it a good job for them. So when we're talking about the programs like WIOA, vocational rehab, the formal employment and training programs, sure, they want to get you at the highest level that you can achieve and accomplish, and that works for you. So I'm not going to tell you that we don't have DSPs, PSSs, folks coming out of the WIOA programs, out of the vocational rehab programs. Of course we do, because that fits them at this time of their life or forever, whatever is right for them. So it all comes down to customer choice and customer need. We like to get them as high as we can, of course, but not really a huge difference anymore, is there?
Yes, and I'm always fascinated by the idea that law enforcement, right? To me, it's a dead end job. Right?
It's
No, I
definitely
mean,
is a small pathway, yeah.
exactly, right?
Mhm.
And, you know, being a firefighter, dead end job, right? Being a mechanic, dead end job. We need all of them, right? Plumber, dead end job. I mean, like these are like, I just think those are all professions that we really honor, right? And value. And so that's one of the questions I sort of have is like, how do we think differently about this workforce and start to develop opportunities that really support a feeder of just the thing, not the what's next. And I don't know how to do that, but it just seems to me that this is an important conversation about just the value of care.
And Jess, that seems to me to tie a little bit into the sort of the marketing campaign that we talked about the other week, just around, again, for me, at least, is what it speaks to. And others can certainly chime in who are there or feel differently, but around the sort of the value of the work that we do, that the mission orientation of this, right, is to, you know, I could go to a hotel and clean rooms there, right? But there's a value add to potentially for, again, Kim, the right individual, they might find this type of work, you know, more meaningful. So how do we create the awareness that's out there for the meaning? But I also, to me, ties into a little bit, and I think this group was talking about it as well from the marketing standpoint, as to, and it ties into what I talk about for what we're seeing from our workforce, as to not only, again, the mission and making it rosy and perfect and wonderful. I mean, talking about also almost debunking some of the myths and stigmas around the population with whom we're serving too, right? Like, oh, I don't want to work for them or those people, right? As to this is a barrier in their mind, we're not a reality, but it's a barrier of their preconceived notions of the populations that we're serving, that, hey, I'm going to stick working at the Hilton and I'm going to make the same, and I'm probably gonna have less benefits and I'm gonna have less of a mission, but I don't, you know, I feel comfortable working, you know, in that environment, versus they could very well have the mission, have better time off and really succeed and thrive there. But they just, again, coming in with that preconceived notion as to, well, I'm going to be working with people that are other, I name it. I mean, they're older, they're impoverished, they're, you know, it's hoarding, whatever it may be that they're going into, that I can't, you know, work in that environment. And again, it's not going to be for everyone, Kim, but is there a way in which we can help sort of reframe this in a way that would allow people that are skilled set and able to do it, that would want to more willingly enter in? So that's something that's kind of been on my marketing mind, if you will.
For sure.
So we're coming to the end of this conversation. Any other questions for Kim? Thank you, Kim. And just taking a brief pause to first of all, welcome Tom Newman and Don Dufour. Do you want to take a brief moment to introduce yourselves? You can start with Tom. Or maybe Tom stepped away. We can start with Don.
Morning, I'm Don Dufour. Recently transitioned over to the Senior Director of Human Resources at Spurwink. Many of you may be aware that Spurwink did acquire Tri-County Mental Health Services, my former organization. So I'm still wrapping my head around the programs and the staffing with Spurwink. And sorry for being late this morning. They moved my office over the weekend and I couldn't get into my system. So thank you very much. I appreciate being part of this committee, and I also appreciate the feedback that everybody's offering. And my concerns, my thoughts are very similar. And Michael, I think you're kind of nailing the point with the need for marketing. I mean, this field, people are called to this field primarily. So I think we really need to draw upon that and really emphasize, how do we do that? You know, it's not necessarily a glamorous job, but people that are passionate about this work, they come to us willingly. But I think there's a whole part of the population that we can educate as to what this work looks like, and they may not even know this is their calling yet.
Absolutely. Thank you. Thanks, Don. Tom, I see you pulled over safely and
exactly. Jess, I knew I wouldn't have to explain that. Hello, everyone. Tom Newman. I'm the executive director at Alpha One, Maine Center for Independent Living. And we do a lot of the stuff that Betsy and Michael's groups do. So I wanted to echo their comments. It was terrific to listen. And the only thing I would add, Jess, that's new to this is I have been thinking about your comment. How do we take something which is a dead end job and feed it. Well, and our care coordinators, that's a dead end job. There's no corporate ladder. We talk to them about that, but we pull them together for collegial activities all the time. I wonder, what can we do when there's such a disparate direct care workforce all over the state? So, maybe something, because it's not, pay rates, it's not benefits at this point. It's how's there some support groups, peer services, etc.
That's a
The
really
other thing I
interesting.
want to add before I get back on the road and when I can't talk is to say, love all this information on apprenticeships, because we are actually starting that now for people with disabilities. I just came back from a week in Charlotte, North Carolina on youth and transition services. And we're all about building not only our peer services, we're going to be hiring from colleges and universities in Maine with an apprentice program. So it's going to be by people with disabilities for people with disabilities. So a lot of great tips on how to run an apprentice program. Appreciate that.
That's terrific. Thanks, Tom. And before we move on from this subject, because we're also charged with making recommendations, does anybody have any recommendations they want to offer up from this conversation?
Hi, this is Margaret. I just had a thought, actually. So I worked in the field for 25 years of serving people with developmental disabilities. But I think that it would be great, for example, to offer some kind of summer internships to high school students that may not have transportation and that sort of thing to drive to other jobs. And especially here in Lewiston, we have a lot of group homes and a lot of opportunities, and for them to just have an opportunity to see how this would work out for them.
I think I would add a suggestion to create a space where employers and the Department of Labor and the CTEs and the I don't know what they're called, the Fed caps of the world can be and continue and have sort of continue the conversations of how of the opportunities and the ways and connecting people together, or some way to make those connections. I get the no wrong door, but that's kind of, sometimes it's hard, to just sort of, I think that having a space where people can come and talk together is maybe another way to advance that. So that would be a recommendation I would have for the Department of Labor.
I am curious for the folks here who are served by sort of statewide provider organizations, and Mallory, that includes you, about whether this information is unknown by providers generally and would be helpful to be shared more broadly, in other words, through some sort of a webinar or educational opportunity.
I would weigh in that yes, indeed, I would think that would be very helpful. I don't know how widely known much of this is. The one chart that we showed a little while ago too, with like all these different avenues, I think was very helpful to me. I haven't seen it before. But I think, yeah, definitely some way of getting this information more widely into the public and into the provider's hands would be really good way to go.
Great.
I concur. I think that chart was excellent, and I was going to ask, but I saw that Catherine already did to have those slides shared with us, because I think there's that stuff on there that I don't know that could be helpful in us, even as care coordination agencies recruiting staff, and I think definitely at the provider network level, I think there's a lot of unknowns that people aren't aware of, that there are multiple resources that if they were tapped into could help them.
So Kim, I'm going to ask two questions. Would you be willing to do a similar presentation to a broader audience sometime in the future?
Found my unmute. Sure, of course.
That's great. And then maybe after we do that, we could put a little working group together that might address some more specifics to Catherine's point, and just look at whether there are some ways we can enhance what's currently available or build something new. If you'd be up for that conversation.
And I'm frantically trying to figure out how to upload that handout so you guys have it right now, but I'll also send it.
All right, great. So let's take a quick break and just see if there's anybody in our listening audience that has a question. We only have 3 attendees listening. If anybody has a question in that list, just raise your hand and we can promote you. Look at me taking over Angelina's job already.
You are always the voice, Jess, and I will just be the button clicker. So thanks for initiating it.
All right, I don't see anybody's hand raised, so if not, we'll just move right on. And just so I think our next order of business is to hear a brief update from our partners, Malory and Ben, related to some legislation that was passed this session, and specifically updating us on sort of what are, if there are any, sort of what the opportunities are in relation to workforce issues through that legislation. So why don't I start with Malory? And if you wouldn't mind, just introduce yourself again.
Yep. So it's Malory Shaughnessy. I'm the executive director at the Alliance for Addiction and Mental Health Services, which are obviously agencies that provide those services across the state of Maine. We had a number of legislative initiatives this session looking at workforce issues. And sadly, we're really not successful with any of those legislative initiatives. The one thing that there was some success on was LD 1718, and we were not the lead group on that. And I don't know, Jess, if you were going to speak to that today. Go ahead. Or was Ben? Because I don't want to take it away from him if he is. Okay.
Go ahead.
Okay. So we had several initiatives. One for behavioral health professionals and trying to expand access to that service and align the credentialing across different sections of Maine Care. That was not successful. It is something we will continue to work on. We had worked quite hard over the last 2 sessions on LD 1506 was to simply convene a stakeholder group to study the training and recruitment for behavioral health professionals. We are doing that work outside of that legislation because that did not come forward. And we had another piece of legislation that we worked on in a coalition with a number of you all, which was LD 1718, which was to encourage participation in Maine's essential support workforce through access to higher education. That did come through, and I believe the final language of that was a pilot where some funding was put into an account to offer a like $4,000 how would it work exactly? So if you are an essential care worker, or you could gift it to a family member, would get a $4,000 deferral of cost or repayment of cost for going on to further education as an incentive to stay in and retain in the workforce. That did get funded, as I say, for a pilot project. We're very excited about that and to see where that goes. Many of the other initiatives, as I said, did not come through the process in the legislature this year. I know that we have several different groups that we're participating on in workforce development. Would you like me to touch on a couple of those, Jess? Okay.
Sure. Yes.
Okay. So we, a number of folks in a coalition on the mental health, behavioral health side, did a point in time study earlier this spring to look at empty positions, wait times for services, and collected a number of data points in a 2-week period. And we're following up on that with some focus groups over the summer with folks who volunteered through that survey process. I believe we had 80 agencies and 285 or somewhere in that realm direct workers responding. So we will be following up with some focus groups over the summer and having a bit of a gathering in September to review the results of that and to try to look forward to, where can we move from here and where can we develop some ways of addressing the barriers that we came up with through this process. That is some of the key work we're doing. We obviously are staying and working with the Access to Care group, which includes many of you folks here, and continuing that work. What I can say is we are continuing to have, major empty positions across the industry and inability to hire and retain for those positions. The end result, as we all know, is lack of access to the services that are provided through these workers. That's pretty much it. It's not a real happy update. But that's pretty much what I have. And we look forward to continuing, the work that we're doing to try to develop better access points. I was really struck by on that chart, the idea of the tech high schools, the CTEs. I think that's a huge area we need to be exploring. Right. I mean, I know on the behavioral health side, there's only one in the state that has any kind of a program that leads into working in the essential workforce for our folks. I think it's fairly similar for everybody else. So I think that's a real key pipeline that we need to be developing.
So, and I have bad news for you. I'm pretty sure 1718 didn't make it.
I thought it did with a pilot.
It did, and it got through the Senate, but it didn't get taken up in the House, as I understand.
Oh, was it carried over too, like some of the other ones? I thought it actually got it. Oh, my bad. I'm so sorry. Well,
that's
no
all right.
successes.
I mean,
no successes to report.
Yeah, no successes from my end to report. All right, thank you. Ben, I'm going to turn things over to you.
All right, thank you very much, Ben Hawkins, again, Director of Public Affairs for the Maine Healthcare Association. Thanks for the opportunity to speak. And we did get some great support from the legislature this session, so here to talk about that and how it relates to workforce as well. I did make some slides. I'm not sure if I have capabilities. Let's see, I'm just going to go for it. Hey, okay. Are we all seeing this MHCA update slide? I'm seeing some.
We are, yep.
Excellent. Okay, so it's just a couple quick slides. If I can advance, there we go. So in the short session, we had a couple bills, but the one that made it across the finish line was the budget, and there was some funding within that budget specific to nursing homes. I also included some notes from what happened in last year at the long session because the funding is kind of intermixed, and a lot of it adds up to rate reform, which for nursing facilities will be scheduled to start January 1st, 2025. And I do have to say, I saw Paul Saucier was able to join is on the call and he's later in the agenda, but Paul, feel free to chime in. You're of course a great collaborator with all of this. So if you have any input, don't hesitate to interrupt me. The first thing in terms of funding is nursing facilities are anticipated to receive a $30 million supplemental payment sometime, hopefully this summer, might be late summer, early fall, because of 90 days for the budget to take effect. Plus, we have to get approval from CMS and other hoops to jump through. And this is very much a necessary injection of funds for nursing facilities. I noted in my next slide, but I think it's relevant now, is in 2022, there was a $96.5 million shortfall for nursing facilities. That gap has been growing over time considerably, and especially since COVID with inflation and a totally different labor market, those costs still continue to climb. So related to rate reform, which we are looking forward to, the rates will be are scheduled to increase by $49.1 million on an annualized rate starting next year. And then what happened specifically in the short session, the biggest change was in the governor's change package. There was $72.8 million to create a special nursing facility reform transition fund. And that is used to, as the name says, aid DHHS and nursing facilities into transitioning for this new rate model. We expect it'll be probably a 3-year transition period. 15 million of that will be half of that 30 million that I mentioned earlier. So I'll go to the next slide, and that brings us to 57.8 million left in that account. If you expect it to be evenly distributed over the course of 3 years, that's going to be about $19 million per year. And again, as I noted earlier, $96.5 million was the shortfall in 2022. So we greatly appreciate the support. It will certainly be incredibly helpful, but the shortfall will still be there. In terms of what this funding can do, there is some language that passed. There are 3 different sections. I just copied and pasted SSS section 1, and you'll note the part in bold that kind of specifies the goals of this funding. It's a time-limited payment to all eligible facilities to reward quality or achieve permanent staffing targets or to adjust the risk mitigation parameters. This funding is intended to support retention and recruitment of facility staff, particularly direct care staff, and facilitate the reduction of the use of contract or travel staff, and may be used for special workforce initiatives designed to meet this goal. So related to that, we are in addition to this special funding, we're collaborating with DHHS on the new rate model. We've had a couple public meetings a few months back going over the proposed model, and now we're meeting with the department in terms of just fine-tuning things and figuring out how we can make this new model as supportive for nursing facilities and its residents as much as possible. So there's a lot of work to be done. I don't have many specifics in terms of how this supplemental funding, what the specific plan is for that. But right now, the rate reform model, for example, it's got guardrails for the first 3 years where rates won't go increase more than 10%, but also they might not, they can decrease as much as 10%. And when nursing facilities are closing, we've had 3 closures just in the first 3 months of this year. The idea of a facility potentially losing 10% of its rate would not bode well for that facility. So we're hopeful that this money might be able to help with situations like that, so a facility doesn't lose 10% of its funding, or to crucially help transition from travel staff, temporary nurse agency staff, or whatever you want to call it, to permanent staff. I think a big part of that is having predictable rates, so nursing facilities are able to know how much money they'll have 2-3 months down the road, so they can work on their permanent staffing targets rather than trying to get care secured for the next week, whether that be with temporary staff or permanent staff. So those are my quick slides and a quick overview. We're looking at some more workforce ideas for the next session and brainstorming right now. So I don't have anything to share there because it might be a bit premature, but I am interested in this extended learning opportunity idea, and maybe there's some room for expansion for direct care workers.
Terrific. Any questions for Malory or Ben? Any other updates anyone would like to lift up related to the legislature? Any questions from our participants? I'm sorry, attendees, our viewers at home. All right, hearing none, I think we are moving on to our next special guest, Paul Associé. Paul, would you be willing to introduce yourself?
Sure. Good morning, everybody. Glad to be with you this morning. I'm Paul Associé, Director of the Office of Aging and Disability Services. And the theme of my update today will be around access. Mallory mentioned the concerns there, and of course, those are concerns all across the board. Ben also mentioned the closures of nursing homes. And so, although it's not a direct way of looking at workforce, it is likely largely an impact of workforce shortage across the board, and it really varies. And the solutions really vary. Ben mentioned contract staffing. I'm not aware that that's really been in use much at all in home care, for example, but it's a big issue in nursing homes. And so the solutions are a little different in each case. So I'll talk a little bit about the recent history of access as we've been looking at it, and the current status as clear a picture as we can look at, understanding that we would like a lot more information. And then there are some really important federal developments that are going to help us along that path of creating more and better data. One is the new CMS access rule, and we're going to look up, I'll share with you specifically information about how it impacts home and community-based services. And then there was a separate nursing facility staffing rule, which for the first time creates federal minimum standards for direct care staffing. And then there's some new federal resources on the scene as well that we are taking advantage of, and that you all should as well if you're not already. And then I'll end with some next steps. Let me put my slides up here. People able to see that? Yep. Okay.
Yes, thank you.
Yep. Did you? There's a lot of slides, but I'll move along pretty quickly, and I'll rely on you to either interrupt me as I go, or we can have questions at the end.
Paul, can you put it in presentation mode?
I will certainly try. I'm not a whiz with this stuff.
It's fine if you can't, but if you can, that would be great.
Is that better?
Yeah, except that we're seeing your next slide.
Slides, maybe close that window.
Let's see.
Can I move it? Haha. How's that? Is that better? Okay, great. All right, so let's see. Okay, so just a little bit of background, and this for most of you is old news, but I wanted to just level set a little bit. Access to long-term services and supports was clearly constrained by a reduction in the labor force participation rates during COVID. Many people dropped out of the labor force at that point for various reasons. That labor force participation rate has improved since the depths of the pandemic, but we are still not back to the participation rates of pre-pandemic levels. And so we still don't have as many people, or as the percentage of people, I should say, who are choosing to participate in the working force as we had prior to the pandemic. Occupancy in nursing homes and certain residential care facilities has improved from the lows of the pandemic, but we've still not reached those pre-pandemic levels. We have surpassed the pre-pandemic levels in terms of access to residential options for adults with intellectual and developmental disabilities. So it's a little bright spot there. And we also have significantly more people participating in home care programs of various types. But the rub there is that the percent of those people with partial care plans has also increased. And I'm going to just very quickly flip through some data points here, again, that you've seen before. These have come in, some of these were presented to the HHS committee, and others are taken from our most recent quadruple A report. So this is nursing facility occupancy over time. A couple of things I'd like to point out here. First, just as I said, we were at 90% pre-pandemic, and most providers will tell you that's where they want to be, maybe even a little bit higher for viability. As of last August, we were at 80%. So climbing from the depths of the recession for sure, but still not up to that 90. Now there was an interruption of the MDS-based reports from the Muskie School, but they have just started again. As those of you who are on that list know that we got 3 or 4 or 5. So if we update this to February of this year, now it's almost at 82%. So tiny climb, you know, been pretty flat here for quite a while. The bottom line is the main care occupancy. So what percent of the beds are main care clients? And you see a sort of inverse relationship here, which is what people assume, right? That the private pay folks are, generally the rate is higher. And so if a facility has the opportunity to take private pay, they will. And you can see that main care was lowest when total occupancy was highest. As occupancy came down, main care occupancy went up. And you see the same thing playing out if you add the February numbers here. This goes up to about 82%. This drops to about 61%. So it may be in part that the private pay market is coming back. This is a combined nursing homes and PNMIC beds. We put them together for a couple of reasons. First of all, we do know that we have lots of people in PNMICs who are at the nursing facility level of care. There's some substitution here that goes on. We also have had several of the recent nursing home closures have been conversions to PNMIC. So we look at these together. When you look at the combined counts, overall, we've lost about 3% of beds in these two categories. The number of PNMICs has gone up slightly, reflecting in part those conversions. The number of nursing home beds has come down. This is residential services for adults with intellectual disability. This is an update from something we looked at a couple of years ago, and we were pleased to see that now both group homes and shared living have surpassed pre-pandemic levels. Here we're looking at the number of people served, and so you can see the steady increase there since 2017. And we're monitoring this in part because we continue to hear anecdotal reports that group homes are closing, and for some people, they're very concerned about this. That may be, but we have more people in group homes today than at any point in the history of the program. And so, with group homes, many of them are leased facilities, many of them are 2-bed homes, for example. And so just an awareness that a home has closed really doesn't tell you enough. It's just an example of how these data are very tricky to work with. And certainly in intellectual disability, we have, for example, not all of these are licensed. So we can't report to you total license capacity because it doesn't reflect the full capacity. So lots of little data issues like that. And in the case of intellectual disability, looking at where people are currently served is a better indicator, I believe. This is the increase in home care programs that I mentioned, and you can see that that's true across the board. The top line here is section 96. That's our PDN program. That's flattening out because our 2 of our 3 service coordination agencies are not taking referrals at the moment for that program. This is section 19, where you've seen a steady increase, a very significant one, actually. Again, these are people who are nursing home level of care, so it could be that we're seeing a substitution effect as the nursing home availability declines. or it could also just be the natural growth in the population. We expect to see that continue to go up. This is section 63, and what you see, this is much more a factor of funding than anything else. We received a significant new general fund appropriation from the legislature from the 131st, and so we were able to completely eliminate the wait list. That wait list is going to start up again soon because now we've reached our new plateau. We're going to land the program at about 1,400 people. This, however, underscores the rub with the home care programs. This is the number of people, and I just showed you a graphic representation of that over time. This is the percentage of those folks who are not receiving everything that's authorized in their care plans, and you can see a pretty big jump from 22 to 23 across the board. 33% to 50% from 22 to 23, and 47 to 62, 53 to 71. So let's talk about the federal access rule a little bit. There are several, it's a big rule, it's 1,000 pages. So just to be clear, it applies to all of Medicaid, not just HCBS, but there are very significant HCBS provisions, and I'm going to talk about a few of the highlights there. So first of all, in the home care world, the state must ensure that at least 80% of the rate that we pay goes to compensation. And there are 3 categories of workers, of direct care workers: personal care, homemaker, home health aide. There are provisions for the state to, if they can justify it, to set a different level for smaller providers. The theory being that, you know, the smaller you are, the bigger your overhead is, because it's harder to spread that overhead over a larger population that you're serving. But again, the state would have to have a strong rationale for doing that. There will also be hardship exemptions, and this will be implemented over 6 years. Now you notice that IDD is not included in that, and it was not in the original. However, it got added to the reporting in the final rule. So the state must report on the percent of Medicaid payments spent on compensation for all of the home care roles, but also for DSPs, which is generally described in the rule as habilitation. And so the big implication here is that we're going to have some way of reporting this. We don't currently get cost reports from any of these providers, for example. We do from nursing homes, so we know how much they're spending on direct care. We do not know how much agencies are spending on direct care. And so we're going to have some kind of reporting or sampling. The rule does allow for statistical sampling. So, you know, it could be that we end up doing a sample of providers, or we, you know, I think everything's on the table for discussion in terms of how we're going to get reliable information so that we can report it to CMS. The state also has to adopt the CMS Home and Community-Based Services Quality Measure Set and report on that every other year. I know I've mentioned this to you all before. They're going to, they did issue guidance a year ago. That's the first set, and they're going to regularly update it with a process that will include public comments. This reporting is going to be phased in over 8 years, with states having to report on a certain percentage of those measures, and then, you know, a higher percentage, and finally 100% at the end of 8 years. We've been trying to get a head start on this in a couple of ways. Last time I was here, I showed you some of the measures we're working on and adding to our published waitlist data. It's giving us a much more refined sense of the limitations of our data, but also what we would need to do in order to report on these quality measures. We also have now completed the first round of CAPS HCBS survey, which is direct from consumer report of their experience receiving services, and we'll be rolling out those results this summer. They're quite interesting. I mean, I'll just give you a couple of top lines. We were very happy to see that most people report being treated with respect, which is great. We were not surprised to see that most people are not getting the support they need to do things in the community. So that's probably a direct relationship to the staffing available to do community support, for example. The state must report annually on waiting lists. Of course, we do that quarterly, but we're going to have to see what the, how part of CMS's goal here, I believe, is to try to get consistency in how wait lists are reported. This is a notorious area for variation across states, even in what they call it. So we'll see what elements they want reported, but we don't see this part as particularly difficult for us since we've been publishing wait lists for quite a long time. It does include average wait time waiting, and we have started to add that to our website. As you've noticed, the measures we have are imperfect for sure. So we'll be interested in what CMS is looking at in terms of how to measure that. And we've got 3 years to implement that. So timeliness, I think this is the one that the 898 committee has been most interested in. I mean, this is a type of what you've been most interested in when you talk about measuring the care gap. So the state has to report annually on the timeliness of personal care, homemaker, home health, and DSP services. And one of those things is the average time from authorization to initiation. In other words, your care plan gets approved. How long does it take until somebody actually shows up at your house? And we have been fielding some measures again on our website on this one. One thing we learned is just how different our IDD and aging services are in terms of when authorizations are entered into the system, for example. So, as you dig into this, you learn that there are potentially false data points that could be put out there based on how we operationalize some of these services. And so I think this is going to cause a very healthy review, and where possible, it will help us try to standardize how we do things across our different population groups where it makes sense. This one, I think, is really the one that gets at what you all have been talking about: percent of authorized hours delivered in the past 12 months for individuals newly approved. So why I think they landed on the past 12 months is A, it's current, right? But also we have learned digging into this method that you've always got this problem of people crossing over study periods. And so if you just always take the most recent 12 months and you look at that, and you look at the people who have come into service in that time, that's a really good indicator of how your system is performing right now in terms of getting those services to people. And it avoids problems of people coming on and off service over time. So that's what they're going to require. Again, we will be interested to see more specifically how that will be measured. And we have 3 years to implement this one. The state, under the rule, has to have an interested parties advisory group specifically to advise the state on payment rates for direct care workers, access metrics, and more. And this pertains, again, to the same group: personal care, homemaker, home health, and DSP. The group has to include DCWs, beneficiaries, authorized representatives of beneficiaries and others. Again, the work that we and you all have been doing in this area gives us a little bit of a leg up here. I think Stephanie is, I think you're on the Direct Care Worker Council, for example. We have that the Ombudsman has been convening with support from the department and Maine Health Access Foundation. And so this will be a very specific place where perhaps representatives from that group and beneficiaries and others can help. The rules gives the state the option of using the Medicaid Advisory Committee for this purpose. We haven't had any internal discussions yet at the department as to how we will approach this, but that's an option and 2 years to implement this. Okay, so moving on to the nursing home rule on facility staffing and transparency, and I'm going to focus on the staffing pieces, although there is reporting in here, so there's some transparency as well, but they go to there are other transparency things about ownership and associations and things like that that I'm not going to get into today. So first of all, one of the earliest requirements here is for stronger facility assessments. These are assessments that facilities have to do today under licensing rules that basically looks at what they need and how they're going to accomplish it in the next year. The rule strengthens the language to make it clear that these assessments are really meant to be sort of real-time assessments based on the residents who are in your facility when the assessment is being done. So more person-centered, if you will, and that the assessment really needs to relate to the needs of people who are in the facility. This is now enforced through Division of Licensing and Certification as a federal requirement, and so I expect that that will continue to be the case. I mentioned that for the first time ever, the federal government is establishing a minimum staffing, and they landed on 3.48 direct care hours per resident, or HPRD. You're going to start seeing this a lot. We've proposed HPRD approach, rate setting approach in Maine's nursing home reform. It is a way that we can all stay focused on direct care. And so, and that's what I like about the technique. In other words, you're looking at how many direct care hours would you expect a person to need and have, it really, and then you price out how much that amount of care should cost. And so it's really a way of approaching rate setting from the perspective of the direct care work, which is, after all, the most important part of the caregiving, is that hands-on. So this minimum, federal minimum, there's a little more time to implement it in rural areas than in non-rural. You can see there 2 to 3 years and 3 to 5, and there will be hardship exemptions. The ratio in particular should not be hard for Maine facilities, and I'll talk more about that in a minute. But the 24/7 RN coverage requirement will be a big challenge, and that's what we're hearing from Maine Healthcare Association and from facilities. Many do not have overnight nurse coverage, for example, or they don't have full weekend nurse coverage. And so as we're talking about reducing contract staffing in nursing homes, that 24/7 is going to be a rub in that conversation, because nursing homes believe they may have to rely on contract staffing initially, at least to meet the federal requirement. And then the state will be reporting the percentage of Medicaid payments spent on compensation for direct care workers. As I noted earlier, this one will not be a problem for us because we already get cost reports from nursing homes every year that breaks down their costs in categories, including direct care. This is a very rough, it's a simplistic, I should say, it's not rough. It's a simplistic comparison of what is in Maine's reform model assumptions that we're currently discussing with Maine Healthcare against the CMS final rule. So our staffing assumptions in health reform add up to 4.48 hours per resident day. CMS is requiring 3.48. And this is why I noted, and this, by the way, in Maine is based on an average case mix. So a case mix index of 1.0, an average resident in a Maine facility. So on average, nursing homes are already staffing at well above the federal minimum. And to that extent, it won't be a problem for them. However, Maine doesn't have a 24/7 requirement. The feds does. And as I say, this is going to be where the challenge is right here. Wanted to just give you a couple more things. Ben did a great job summarizing where we are with NIF reform, and I'll just give you a couple of the features. First of all, the proposal includes value-based payment to reward quality for the first time in nursing homes. That's not been done before in Maine. The staffing levels that we have proposed for nursing homes are well above the minimum licensing requirements in Maine, and now we know they're also well above the federal requirements. And we've also built in an incentive to increase employed staff and decrease contracted temp staff, really for two reasons. The contract staff are very expensive. Those of you who've used them know. But also when you have it, I want to be very clear on this point. The qualifications of contract staff are just fine. No issue with the individuals. However, they're coming in for a 6-week stint or less, and then they're leaving. And so you cannot work on the quality of the facility when you have a significant portion of your staff that are just cycling through the facility at any given time. And then, of course, it's been well discussed a lot that it contributes to poor morale in a facility because they're working side by side with an employed staff who's doing the same job and making a lot less. So it's really a formula for disaster, and something that we're very pleased that the Maine Healthcare Association wants to work with us on how we reduce the number there. In terms of direct care, the price in the state's proposal is based on 4.48 hours per resident day for, as I said, for an average acuity case mix index of 1. The wage assumptions in the model are above the 75th percentile. So what does that mean? When we look at Bureau of Labor Statistics data for Maine for the professions that we're looking at, so RN, LPN, CNA, we've made pricing assumptions for those roles that are in the top 25% of what Maine employers are paying for those roles. And so that is an indication on our part that we understand that it's a competitive industry, and nursing homes are competing with many other entities, hospitals and health systems being the biggest in terms of nurses. And so being able to pay competitively is an important part of reducing the contract staff. And then we're also looking at incorporating some kind of staffing level or staffing stability, perhaps looking at turnover, something like that, and value-based payment. More to come on that. We're looking forward to reconvening the Innovation and Quality Council this summer. There are several really good clinicians who serve as medical directors on that group, and we really would like their input on, as well as other interested parties on the measures that will be used in the value-based payment. Pleased to report that Maine's been selected for a National Academy for State Health Policy, State Nursing Home Policy Academy. This is something that West Health has funded through NASHP. The goals are to strengthen state policy on nursing home quality, payment, and engagement. We just learned last month that we've been selected to participate along with 8 other states. All states that are engaged in various types of reform. So that's going to be a big help to us, and we hope that that our ideas will be helpful to them as well. There has been a federal HCBS workforce work group meeting, they have come out very recently in April with a report on data, this was a federal HHS and DOL work group. And so I mean, I just didn't see a whole lot in the report, to be honest with you, but in case you haven't seen it, I've included the link here, and I'll send these slides to Angelina so you can access them. The recommendations are pretty much what I think everybody already knows in terms of the existing data being very scarce in this area. But they've recommended regular national surveys of direct care workers and adults with disabilities. So it would be something like, you know, the American Community Survey that the Census Bureau uses as a way to kind of figure out what's going on at points in time. So I think that's what they're recommending here. They want to promote consistent state data collection efforts, and they want to maximize the use of existing federal and administrative data. So again, nothing too specific in it, but you know, I think that the emphasis is right and the direction in terms of what they're saying is right. And it certainly brings attention to an issue that you all have been very familiar with, but I just don't know if there's general awareness in this area. That work was supported by the Direct Care Workforce Strategies Center. This is one of the relatively new federal resources that you all should check out. If you haven't already, it's funded by the Administration for Community Living, and it's operated by National Council on Aging in partnership with several national organizations, all of the state associations, you know, Medicaid directors, DD directors, and others are all involved in this. And they're offering resources on the whole list of things there that I won't read to you, but everything from recruitment and retention to family caregiving. They have initiated a state peer learning collaborative, and I'm pleased to report that we've been selected for that as well. We'll be one of 13 states that is going to share best practices and strategies for the rest of this year. So what's next for the department? Certainly the access rule is going to be a big focus here at ODES over the next few years. We have put a request into CMS to use 9817 ARPA funds to do a project on an assessment basically on our readiness to implement the access rule. We're hoping to hear back from CMS very soon on that and get started on that work this summer. We will be assessing all of the things that I mentioned earlier, including that interested parties work group and how best to address that. And I expect that we're going to be wanting to engage you all and others quite a bit along the way. As I mentioned, we're fortunate to be able to participate in 2 national collaboratives, one on HCBS and one on NIFs, working with the Maine Healthcare Association to implement NIF rate reform by the 1st of January. There are rate studies underway that impact this. The Home and Community-Based Services, Clinical Services, and Service Coordination rate study was recently kicked off. That's looking at the nursing and other clinical services that are in our home care and IDD programs. And it's also looking at the rates we pay for the service coordination itself at our service coordination agencies. We are looking to launch the new lifespan waiver for intellectual disability next year sometime. And so we're doing a big rate study for that new program, and we're using as a basis for that a rate review of 18, 20, 21, and 29, which are the 4 IDD brain injury and related waivers that we currently have. And they'll be we'll be rolling out proposed rates very soon for that. And then the nursing facility rate reform, that's ongoing work. We have a proposal out that we're talking to Maine Healthcare about, but we've also decided that we will update the model with the cost reports that are due at the end of this month. And so we're going to do a little updating of the model just to make sure we have the most current cost information in it. But I expect that this summer we'll come to a final rate package and be in a position to implement that on January 1st. And then, you know, these are the ongoing areas that we're asked to report on every year in the Part Quadruple A report. Reimbursement, recruitment, development, et cetera. And I know you've heard all that stuff before, so I'm not going to take you through an update of all the stuff we're doing in those areas. But we did issue the 3rd annual report in February. We'll do another one next February, and we'll continue to work on that. So that's what I got.
Great. Thank you so much, Paul. Any questions from folks? So I have one, which
I'd be surprised if you didn't, Jess.
I know, it's so true. So I appreciate first of all, wow, great job. That was like covering a huge amount of territory. And it made sense of a lot of information that's been coming from the federal government. So thank you. We remain interested at least partially on folks who aren't getting served. And as you referenced, as we've been talking about it, this care gap, and just curious if there is any strategy. I didn't see anything sort of for how you all are thinking about managing people who aren't getting care in a different way, if you are. I mean, just sort of even understanding what's happening to them, because it seems to me this administration in particular has been very thoughtful about all kinds of reforms and reducing costs and increasing outcomes, I think. And we have a population of folks, particularly, I'm wearing my MCOA hat for right now, older people that it's very clear to me we don't have any idea what's happening to people who aren't getting care either from the homemaker program or home care, and what's happening to them. Are they ending up in long-term care? Are they ending up in hospitals and unable to be discharged? What's the plan for understanding what the impact of this care gap is?
So there's a couple of parts to that, I think, in terms of, first of all, I think we should acknowledge there are people who are out there who never even approached the state or a AAA or anybody else for anything. And so there are needs out there that none of us are aware of for sure. For people who are coming to us and being placed on a wait list, I think, you know, I would turn to the service coordination agencies in terms of, well, if they're on a wait list, they may not be getting to the service coordination agencies. I'm not sure how Catholic Charities interacts with people on its wait list, but I think there's some case management that occurs, and so that's what's happening there. In terms of people getting some but not all of what's in their care plan, I think that is managed by the service coordination agency, depending on the needs of, but also on what's available. Where the clinical services rate study will be important because, you know, we're told that nursing services are harder to get than home care or homemaker services, for example. So there's a range of things that happens out there for sure.
I'm not sure that, I mean, is there any move afoot to actually manage or to know? I mean, is the department interested in knowing? I'm just curious about that. I mean, sort of the longer range. Are we spending more money on people because they're not getting care, or they're not getting home care? Are they, you know, I mean, have we done any looking at this information? Sort of what's happening to people who aren't getting care? I'm not talking about wait lists, you know that. I'm talking about people on 19 and 63 who aren't getting any home care.
If they're enrolled in the program, they're getting something. And should we look at where they're ending up? And I mean, I think that would be good to know. I think where we've been focused primarily on how we build the capacity up so that people can get what's in their care plan, and how we can do a better job at measuring this.
Okay. Any other questions?
I just, I guess more of an observation or a consideration, as the, you're sort of sorting out the RN at all times in the. I'm on mute. Can you hear me? Sorry, I had it. Sorry. So I had, did you hear anything I said?
We did. You just turned
okay.
yourself off.
I don't know. I moved my keyboard and I turned myself off. I must have hit the mute button on it. The sort of the trickle down effect, you know, so when considering sort of like how to manage, you know, the change of the RN or the staffing hours that you're doing in nursing home reform and all of that, you know, from where I sit, and specifically in the ICF program, which is, I know, very small, but very important in our state. I'm concerned about that, you know, staffing even being further pulled away from that program or other types of care programs that use nursing or may use CNAs. So I just ask that is part of the consideration and part of whatever remedies are put in place, that is considered also, that impact is going to probably be felt pretty real. So that's all I have to add.
Yeah, I'm not sure I'm really getting the question, Catherine, but I think you're saying, as we look at nursing requirements in nursing homes, are we concerned about the impacts on ICFs or home care agencies or other settings? I mean, that's always a concern. And I think, you know, it's a limited pool, right? And there are efforts going on to increase the number of seats in nursing schools, et cetera, et cetera. I mean, there's supply work going on, but the reality is there are not enough nurses to go around. And so, you know, I should have reported on this earlier, actually, but our legislative success on nursing this session was to get a nurse delegation bill passed through the insurance committee. And we're working very closely with the Board of Nursing on that. We think that will be most impactful in the home care arena, where many health maintenance tasks under the bill can be delegated by a nurse to an unlicensed personnel. So someone like a home health aide or a PSS. That should expand the ability for people to get some basic health maintenance in the home without a nurse having to show up each time. The Board of Nursing has to issue rules on it, but we're very excited about that development. That said, I mean, it's a market out there, right? We don't control the market. We try to do what we can to stimulate more supply of certain professions where we can impact that. And then, providers are essentially all competing with one another. I think one of the things that I've feel strongly about is that collectively, we can't let up on the marketing and recruitment, right? The supply, we have to keep working on that, multiple ways to do that. However, from what providers tell me, the turnover is, it can be between 40 and 70% a year. And so we need to work on retention. I think we're probably going to get a bigger bang in the short term if we can improve retention rates. Then we will, it will take several years, right, to get more nurses graduated in the state of Maine. But both things are important, don't get me wrong. I just think we need to look at retention harder.
Yeah, I absolutely agree. And I don't think I had a question as much as an observation and a request that trickle down effect is going to be impactful in those other programs. So as you're moving through sort of that implementation of the nursing home staffing regulations, that is a consideration that's made in
if I can add to that, Catherine, I think one of the benefits of the CMS regulations, because LPNs haven't been listed, it's providing more opportunity for LPNs. So in other settings.
Yeah.
We're certain, we certainly have a ton of LPNs, good LPNs that work for us. And sometimes they're passing meds, but when the CMS regulations come into play, depending on what those LPNs are doing, it could push more towards the other delivery systems. Yeah.
And of course, LPN is something Maine kind of moved away from and is now back to, that provides that career ladder too, I mean, I actually want to comment on Stephanie's comment from much earlier about DSPs who don't want to advance. I'm not sure I would put it quite that way, Stephanie, but I know what you mean. People who are they're caregivers, they're supporters, and that's what they want for their career. That doesn't mean we can't build a career into that. And so, for example, I know this is giving some providers a lot of stress, Catherine, but on the lifespan discussion, we're talking about perhaps having differentiated levels of staffing expertise, right? So maybe that translates to a DSP1 and a DSP2. And the DSP1 is what we cover with our core curriculum. And the DSP2 is, you add a dementia unit, or you add a behavioral unit, or you add a medical unit to get, and I think there are a lot of people who do want to stay as caregivers for sure, but that doesn't mean they don't want to learn new skills, be better at their job, be able to serve people with more complex needs, I think.
Yeah, I mean, I guess I'll just take a moment to add the extreme success story at our agency of a wonderful LPN. Well, she was a DSP in our group home services, and she went back to school and she became an LPN, and she moved to a different part of the state and became an LPN in our ICF. And so she's doing, she's career advancing, but her work in the caring field is very much the same. And it's been a huge success for our agency and for her too. So,
and I agree with you, Paul. There are different tiers within the DSP realm, and I meant
management. Yeah,
advancing management wise.
Right.
Yes. Yes, and I really, really do like the DSP one and 2 model. And look forward to being able to make use of that.
Okay, any additional questions from advisory committee members for Paul? All right, just checking in with our folks viewing from home. Any questions? If so, please raise your hands.
Well, this is Margaret, and I'm on
Go ahead,
the.
Margaret. Yep.
I wanted to know what's going to happen to licensing if people aren't going to be able to comply with having 24/7 RN on staff. Is there going to be, sanctions, or and what can be done on, maybe our federal delegation can try to mitigate that somewhat.
Yeah, thank you, Representative Craven. First of all, we do have time to work with the industry to implement this. So I think I'm hopeful that everyone will be able to comply. Then there's a slightly longer time frame in rural areas where there does seem to just be a smaller labor pool, right? So maybe it's a little harder or harder to get people to go to a remote location. And then there's room for exemptions. So hopefully we will get everybody compliant. I think, and we haven't talked about what the sanctions might be and so on, because this is a federal rule and DLC, Division of Licensing and Certification, will be acting on behalf of the feds here. I'm guessing they're not going to be given a whole lot of leeway, right, in terms of what can or can't happen. So it'll be an ongoing conversation, I think, but I believe everyone shares the goal of, not closing a nursing home because you can't get the 24/7 met.
Thank you. Angelina, we don't have any questions, right? I didn't see any either. All right. Thank you very much, Paul. And we will move on to our next agenda item, which is an update on the DSW, Direct Support Worker Training Plan. And I think we got a memo from Abby because she can't be here. Paul, do you have anything you wanted to offer on that?
Well, happy to answer any questions. Basically, we're getting very close now. I think you're all familiar with this project. It was recommended by the original Workforce Commission that we go back to some early work that had been done under a HRSA grant. That's the Federal Health Resources and Service Administration. We've got most of it updated and loaded now. We have some national subject matter experts, but also some state subject matter experts who are looking at it, providing an initial round of feedback. And once we've fine-tuned it a little bit, we're going to put it out for a broader review, likely this summer sometime. There's a meeting coming up in the DSP world on June 7th to provide more details. We're going to do a similar webinar for people on the PSS side. The earliest that we see the core credential going into effect would be the fall. And there's a lot of transition provisions that have to be worked out. For example, we do not see flipping a switch one day and everybody has to get recertified. We foresee letting people's existing certifications run out to their, and then as they get recertified, they would come on to this new curriculum. The curriculum is greatly updated. I think people in both the PSS and DSP worlds would say curriculums needed an overhaul. That was tried on the PSS side a few years ago, and there was a lot of concern about the new curriculum. And so all of which is to say, I think just from an update perspective, this has been needed. The innovation here is that there will be one core credential that enables you to get started either as a DSP or as a PSS. And we then will turn our attention to advancement, as I was mentioned earlier. we foresee being able then to add specialty modules onto this for people to who want to do more complex care. But that'll be in a future phase. So happy to answer any questions.
I just put it in the chat. Is there a link or more information on that June 7th meeting?
I don't think it's been publicly announced yet,
Okay.
Catherine, but I'll if it has been, I'll get it to you, and otherwise watch for it. We'll announce it on our listserv.
Okay, great.
Yeah.
Laura would probably also get it to Laura. I'm sure
Yeah,
that's
yeah.
probably want it more than me, but thanks.
Any additional questions on that?
You might not be able to answer it, but I think one of the questions we had was the length of time it takes somebody to be credentialed, and does this anticipate that it's going to take less time, more time for a PSS, less time, more time for a DSP?
Boy, you're really taxing me now, Catherine. I think it's 40 hours, and I think it's comparable to what's happening today.
Okay.
But don't quote me on that.
All right. Thanks.
Other questions for Paul? Okay, well, that went fast since Abby's here. So I think maybe we are at the end of our agenda, although what I would like to talk about are whether what folks would be interested in learning or discussing, diving deeper in our next meeting, which is again scheduled for August 12th. Am I getting that right? And just as a reminder, we are to make recommendations to state agencies and the legislature related to recruitment and retention of essential support workers, monitor the essential support worker shortages and the expansion of essential support workforce, to examine if actions taken have actually expanded the essential support workforce, make recommendations to DOL, DHHS, legislature, and other agencies regarding additional research needed to further the expansion of the essential support workforce, collect data related to essential support workforce, examine the benefits cliff, and make recommendations to the legislature, including suggested legislation. So I just want to put that out there to say now is a time that we could talk about additional information that we're interested in learning, and also any recommendations we want to think about, even just working on toward the future, in the future. So I'm going to open it up for any comments, thoughts, questions.
I think it might be helpful to do kind of an analysis of, and I know we had talked about this a little bit, Jess, about, each the recommendations that were in that report and the status of them, and sort of, it would be helpful. I do well with the visual, so it would help me, I think, to take some time to look at that and kind of re-evaluate our priorities maybe, or identify them.
And I could go back to talking about the Maine health data. That it was a real, even if we had gotten that in a bill this year, it probably would never have processed through because of what happened at the end of session. But I think that was still a great idea to get the Maine Health Data Organization to do the research for for not waiting.
Oops, you went on mute, Margaret. Sorry.
But what the amount of services that people get, if they're, getting any, if they're waiting, that sort of thing, to do the nitty-gritty collection of information that, and again, I feel very guilty and bad that didn't go forward this year, but given the short session and all the craziness, it's like, eh. But
You have to let that go, Margaret.
I think it's still a good idea to do that.
Yeah, I am curious, and if there's you not to put you on the spot, Paul, but you had reference to in our last meeting that was in relation to asking some questions. Well, that's something that MHDO could do if they were doing that work. I mean, is there any way we could fund something like this that would start to get at some of these questions? I really think, again, this idea of understanding ultimately, and I know it's one of the reasons why they were particularly interested in doing this work, right, is thinking about this in a much broader context, which is why I asked you those other questions. I mean, yes, do I care about the individual person? You bet I do. But I'm also looking at this right from, we all know that if we don't, it's the pulling people out of the river, right? We can keep pulling people out of the river, or we can go upstream and say who's pushing them in. And so, but if we don't even know what's happening to people who aren't getting care or aren't getting enough care, then we don't know, right? Are we spending more money on this situation than if we invested more in this workforce? And we can all agree to disagree on what that looks like, or how we might do that, but at least having the data available to help us understand what's happening seems like it's a really good thing to do.
So was the cost around $80,000 or something? It wasn't. It didn't seem like an amount that was unsurpassing.
And Maine Health Data, I mean, it's what they do, right? And so we work with them a lot. We value and respect their work. So no issues with Maine Health Data Organization. We're I think our concern when the idea first came up was the access rule was coming out, which so what we would not want to do is create a whole data set that does not meet those federal requirements, because then we've got to do a whole other one. And so we need to do something like that. I think the specific ask in that proposed bill was problematic in many ways, but we're open to talking about that, and we are always open to partnering with Maine Health Data. They already get claims. For people who are not familiar with them, they already get all Maine Care claims. And one advantage of looking at Maine healthcare data is you could also look at what's happening on the Medicare side, because they also get Medicare claims.
Right.
And they get private payer. And so you could really have a comprehensive look, which would be much better, right? I mean, let's move this debate. Let's bust out of the Maine Care box here and look at everything. If we can, it would be much better.
I don't disagree with you. I think, we continue to fall into this challenge of how do you, so yeah, anyway, how would we ever know, right? Oh, this is the downside, right? How would we ever know that someone on Medicare who's gone to the hospital went there because they couldn't get a direct care worker? I mean, there's just no way. The causal piece is missing, right? And it's not to say you could actually make a causal connection if somebody's on Section 19, isn't getting care and goes to the hospital. They might have had a heart attack that was completely unrelated to not getting care, right? So, I mean, I get that completely, but when you start to look at this, right, situation to understand, are we spending more than we need to be spending because we're not managing a population? I mean, this is the main Medicaid reform writ large on many different levels, right?
Yep.
Why primary care practices do a better job of managing diabetic people, right? I mean, like, it's about cost, right? And so if we don't even know what's happening, then how can we begin to say, to strategize around just managing this population in a different way. It might not even be providing more services, right? Just different management. So
yes, and I think the type of research you're talking about, just as you know, is complicated, but it starts with a good data set. So I think starting by working with MHDO or the department or somebody to create a good data set from which we could do these longitudinal analyses. Where are people ending up? Where are they going? You know, it's kind of the holy grail of aging research, really, but I think it's possible.
And do we know that hospitals don't track that kind of data about who's ending up in their emergency rooms and why?
Well, we do.
Should we be asking the hospital association to see what kind of data they have that might be useful?
Yeah, they come to committee and, acknowledge that there are people in the hospital for weeks and months sometimes because there is no place to discharge them to, whether it's a nursing home or having home health care at home. So we do know that it's happening for sure.
And that's the flip side is we can't get them out of hospitals. I think Paul's question or Mary Jane's question was just, is that the cause of them coming there to begin with? And that I don't know, but I think it's a really good question, and we can certainly ask the Maine Hospital Association to come next time around and let us know what kind of data they do collect on this. And Tom, I saw you come off mute, and I'm sorry, this may not. I'm just going to see if you've got something you wanted to offer.
I did. I'm on dry land, Jess, and was able to figure out how to use this iPhone for a Zoom meeting, which was new. And what I wanted to do is this work we've been doing for quite a long time, and we sometimes don't celebrate our wins. So I want to throw a shout out to Paul and the department because we have had success in enhanced recruitment of personal care attendant in the consumer directed programs as a direct result of the increased reimbursement rates. Pre-COVID, when I was at Alpha One first starting, I think the pay rate in Section 19 was like $11.50 an hour, which was above the minimum wage at the time. And it's over $22 an hour now for all the FIs, Seniors Plus, Alpha One, GTI. And that's a result of hard work by the department. So every once in a while, Paul, you get a positive at these meetings. I want to throw that out.
Thank you.
Because
I'll take it.
we have been able to, at least in consumer direction programs, increase the workforce. So much so that in some of the agency consumers, when they just can't get staffing, we go through enhanced skills training and try to help them convert to consumer direction. And, a small success story among many, many problems we need to continue working on. So I wanted to throw that out now that I'm not driving.
It's also a reminder that there, as we've been saying for this whole meeting, there are multiple strategies involved here because the reality is that the workforce is probably not going to grow at the rate we would all like it to. And so self-direction is a big part of the solution, and we are seeing it grow a lot. It shouldn't be a substitute for formal care for the people who want it, but many families are very delighted to do the self-directed care with a family member.
Other comments, questions, recommendations? I will say we have pulled out the, 30 plus recommendations of the commission to study long-term care workforce issues. And what we can do is put it in a spreadsheet in a Google Drive and share it with folks. I have to admit that I have a lot of information, but I have yeah, I know that happened. I know a little bit of that happened. I know a little bit to be dangerous, but I think it'd be really nice to maybe put the recommendations out there and have us all sort of say yes, no, something, and see where we have some more room to make up, if that would be helpful.
I think so, Jess. I think sort of what I was thinking was taking stock was the term that came to me, was just sort of maybe that August 12th meeting, and leading up to it is that we put all of those recommendations out there, see where do we stand with any one of these, and are there some that really are not relevant any longer because we've sort of looked at them and said, you know, maybe that one doesn't really meet what we're trying to do, or are there new ones? So yeah, I feel like we're at a place that we ought to be doing that.
Yeah, there's definitely one that's out, which was something around a rate reform, which happened, right? I mean, we did pass rate reform, but in a different way than the role was. So yes, there's definitely some we can get rid of, some that we've made a considerable amount of progress. And I think to Tom's point, celebrating some of that is really a great thing, but also sort of seeing where we have some room to make more progress would be great. Okay, well, on that note, I think we can end early. What a great thing. Give you back, I don't know, 40 minutes, almost 38 minutes.
I'll take it.
I will too.
For someone newly back from vacation, I can use it. Thank you.
All right, well, our next meeting is August 12th, and Angelina will send us a calendar invite if she hasn't already. We'll put together an agenda and make sure you get it in advance. And thank you all so much for your work.
Thank you, Jess, for chairing.
Thank you. Have a great day.
Bye.